44-year-old lady with a history of diabetes. She's known insulin-dependent diabetic with mild non-proliferative retinopathy at a previous screening.
This is a female who's a known non-proliferative diabetic retinopathy sufferer, so she's insulin-controlled diabetic. Blood pressure's 140/90. She is obese, but she doesn't smoke, and the alcohol intake is about 6 units a week. She works as a healthcare assistant, and she has normal intraocular pressures, 618 in both eyes. Her acuity is 618 in the right and 612 in the left. She came in complaining of a sudden onset of blurred vision, and we know that she only had mild non-proliferative diabetic retinopathy at her last screening visit. So this patient's a self-referred lady who's complaining about reduced vision. So if anybody would like to start us off, tell us what you think of the images to start with.
It looks like there's some sort of edema going on there, doesn't it?
Right. How do you know there's edema there?
Because there's there's a build-up of fluid.
Right.
The black patches don't like the fluid, I think, from what I've read. So I'd guess it was some sort of maculopathy.
Good. Anybody else?
Seems to be some cystoid areas, so consistent with cystoid macular edema.
Does anybody else agree that cystoid macular edema there?
I would, because we're seeing big black gaping holes towards the inner portion of the retina rather than the outer, sort of from, I think it's the outer plexiform layer inwards. So there's certainly some intraretinal fluid. Looking at the photoreceptor layer, there's usually a little bit of a bump there, but there's also a slightly darker area underneath it, and I'm wondering whether that is actually normal or whether that is slightly abnormal.
Any other view just in that particular area?
It's very easy to jump to conclusions and say this is definitely due to the diabetes, but it's not necessarily the case. It could be the diabetes causing the problem, but there are other reasons as well why this could be, as Kerry said, a cystoid macular edema type problem.
Do you think that's the reason for her sudden onset of blurred vision, or could there be other reasons?
I would think so.
Would have thought so, but then also we've not talked about anything else, like are there any lens opacities, for example. She's only 44, but that's always a consideration.
Is her blood sugars controlled?
I don't think we know that.
No, so it could be a myopic shift. Could have occurred.
It could be. So could this have been here for a little while then, do you think?
Mm-hmm.
It's possible. The concern also is the other eye has got only 612 vision. That makes me slightly suspicious as to something going on in the other eye. We don't have that information at present, except to say that at her last screening she wasn't so bad. She had mild non-proliferative diabetic retinopathy. And whether this is early proliferation or macular problem isolated to the macula, I can't really tell.
What about the reference image that we've got there? Would that give us any clues as to what might be going on? Perhaps the fundus image would be good to look at.
Certainly some hemorrhaging going on. Dot and blot.
Over just the macular area or over a wider area, do you think?
Wider area as well.
Looks like non-proliferation in the arteries there, gone suddenly pale.
And some small exudates maybe, inferior temporal to the foveal area.
Possibly even a little bit above that as well, just superior temporal. Between the blot hemorrhage and the fovea, there's sort of a couple of little yellowy speckles as well. Could be exudates. The bit I'm worried about, there's a small arteriole that seems to be coming from the disc that goes white halfway along.
Yeah. So what would that be suggestive of, do you think?
Looks like poor perfusion from that area, hence causing possible edema.
So do you think that could be related to the sudden nature of the symptoms, or do you think it's more likely to be refractive or blood control, glucose control?
Very much doubt that it's refractive. looking at the OCT and looking at the fundus photo.
Assuming she's in our chair, are there any other tests that you might want to do just to help you with that?
Amsler would always be good.
Amsler?
Pinhole acuities would be nice to have as well.
Pinhole would help, but perhaps, yeah.
Colour vision, some sort of colour vision testing would be good as well.
And what would you say the differential diagnosis could be? Obviously, diabetic retinopathy is clearly one of them.
Could be ischemic edema.
Yes.
Could be a branch
Retinal artery.
clearly.
Yeah, that's what I
It
was
could,
thinking.
yeah, I would guess.
Yeah.
In that case, if we've got those as an option, we don't really know what from the information we're provided with what the vision was like before, which would obviously have helped. But what would you be doing with that patient?
I would refer very soon for further investigation to an ophthalmologist, a medical retina ophthalmologist.
Right. When you say very soon, how would you go about making that referral then?
Again, it's very area bound, and I'd be very tempted to send this one to Casualty because I feel so insecure about the diagnosis. So it's because I'm not sure that my level of urgency changes. So
Okay,
I'm treating myself rather than the patient, perhaps.
That's probably quite valid. Let's see what anybody else thinks. Has anybody else got a view about how soon we should send that and what reasons might be?
I think ideally, if you could specify a time, you'd want that patient to be seen really quickly. But if you send them through a normal GOS 18 referral process, I haven't got a great deal of confidence that that patient would be seen at the time that you want them to be seen at. So there's potential delays, and that creates an issue then. So do you refer it to Casualty, knowing that at least that patient will be seen?
Do you think that it's likely this patient is already under the care of an ophthalmologist based on the images and the known?
Probably not based on their last retinal screening, where it was, I think it said mild non-proliferative diabetic retinopathy. So presumably they're not under the care of an ophthalmologist.
Do you think there's any signs here that maybe that situation's changing and therefore your approach might change?
Well, there's an escalation since the retinal screening. So if you refer, they need to be under the care of an ophthalmologist.
It'd be less to know when the last retinal screening was as well, or whether it was a few weeks ago.
Presumably it will be within the last year, but let's say 6 weeks.
Fine. Then, if it was 6 weeks ago, it would be more urgent for me.
So, but do you think there are any other clues in the multicolour fundus image that might suggest a kind of change in status?
The tortuosity and artery to vein crossings look suspicious in that her blood pressure was noted as 140/90, which is slightly up but not very much up. The fact that she's obese doesn't help, especially being diabetic. So generally, her artery vein crossings look like she may have high blood pressure as well. So I wonder about her control.
I'm wondering about the small vessel that we highlighted that goes white near the disc, has a little small red squiggle coming off it. Is that a new vessel? Is that collateral?
Well, I was wondering what you thought about that.
I think it is a new vessel.
Do you think does anybody else feel, having heard somebody else voice that they would go along that route?
Yeah.
I think that's a sensible suggestion.
Yeah.
So if that's a new vessel, does that change your view about how urgent this case may be, do you think?
I think we're already suggesting that it's seen very soon anyway. So I don't think it adds any other layers of urgency to it. It's already fairly urgent.
So in your area then, what would be the pathway that you would use?
Well, by rights we should be using a GOS 18 for urgent opinion.
And anybody else?
Yeah, the patient in this area would be sent to eye casualty department because otherwise, as Ian suggested, they may be lost in the system and not be seen for many weeks.
So really for administrative reasons and to just ensure that the patient doesn't get lost to follow up.
Yeah, also, it's emotive because this condition is obviously sight-threatening.
Right.
So it would affect that person's lifestyle possibly in the long-term future if nothing was done soon.
What you're saying is that you would err on the side of caution because of the potential threat to this patient's vision.
Oh, yeah, definitely.
And has anybody else got a strong view?
Well, I think it's urgent, and in my area, if you phone up the ophthalmology on call, you can usually get through and speak to someone and say, look, this is what I'm seeing, rather than sending a letter and letting it pile up with all the cataracts and glaucomas. And they'll make an appointment at some point in the next few weeks that way, rather than it, because you can't do urgent via GP, it just doesn't always work. You can't rely on it working. So yeah, if you can speak to someone, this is the time, I think.
Presumably, Kerry, then you then document that on the record that you've spoken to
Yes.
whoever the ophthalmologist is?
Yes, if I can get their name before they hang up as well, I do.
Perhaps you should ask before you to speak to them what your name is.
That's a very good idea. I shall adjust my procedure accordingly.
Okay, so I think we're going to send this patient off. I think everybody's quite clear about that. Nobody would consider monitoring this patient in practice.
No.
No.
No. Okay. Okay. Now, when this patient gets to hospital, do you think that they'll do anything different? So, what investigations do you think that patient might undergo, so that we can explain to her what to expect?
It'll start. The patient will initially be dilated, fundus examination, followed by an OCT because it's easy and it's round the corner. And also, by routine, they'll have a fluorescein angiography done with the necessary cautions. And then appropriate discussion regarding medication and possibility of laser, I suspect. So I think some idea to the patient would be nice. Tell them what they've got. Also explaining to the patient helps, and that they can understand the urgency and deal with it.
So that they don't just kind of bury their head in the sand.
Well, it's not that. I think without appropriate discussion and information, they're not in control of their own illness, and they may think it's not so bad. Or, even worse, they may think it's worse than it actually is, in that there's no treatment available, there's nothing that can be done. And that can worry patients an awful lot.
Yeah.
So putting them in the picture. A nice thing to do, I feel, is a follow-up call maybe in a day or two to see how they are, if they have any concerns.
Which gives you a chance to
Yeah.
reassure them or otherwise.
Yeah, it's not managing just the eye, it's sometimes managing the patient.
Okay. Has anybody else got anything to add to that?
I don't think so.
So if we're sending this patient direct to the hospital, would it be appropriate to keep the GP informed?
You always send a copy of the letter to the GP anyway, just
Right.
for their records.
Is there anything particular you might want to get the GP to do in the meantime, given your thoughts, some of the things that you've voiced?
I think a cardiovascular review would be sensible.
Is anybody else confident enough to actually suggest the GP might like to do that?
If I can add a slight side view, in this area we're looking at reviewing we're actually doing it currently, the pathways for referring patients exactly like this, whereupon the patient would go directly to the Fasttrack system,
Right.
with suspect diabetic maculopathy, and a copy would go to the GP with the request to do blood tests, so that by the time the patient's been seen at the hospital, they've got up-to-date blood test results and a review of medications as well. So hopefully that would cut time down.
That sounds like best practice.
We may have the system
That's
in
good.
place within the next couple of months.
Sounds fantastic. Has anybody else got anything like that in their area?
No, not at all. I'd send a copy to the GP and say, you might want to review this person's cardiovascular health and is their diabetes under control.
That's good. Anybody else got any other comments about what the patient might expect when they're investigated at hospital?
We talked about investigation and treatment-wise laser, but aren't there now possible steroid implants that might help improve things? Is that right?
Not in this area so much, but yeah, they could have possible anti-VEGF treatment for this sort of thing, and it's also possible to have triamcinolone injections, But I wouldn't go there, because if my initial diagnosis wasn't exactly correct, I wouldn't want to have that discussion with the patient or suggest it to them at this stage. Because I don't feel fully confident to say this is the direction you're going to take. So I wouldn't go to that discussion with the patient.
But it's a valid point. The patient could be offered that type of approach, possibly depending on what the consultant thinks and what the local situation is.
I think it's just that we can encourage the patient by saying there are treatments, there are things that can be done, but we need to get you to see someone to make that decision.
It's a shame not to treat it, isn't it, given her age? She's got a lot of life left in her yet. This is good. So anybody else want to bring any points to the discussion? Anything further? Okay, thank you.
She's known insulin-dependent diabetic with mild non-proliferative retinopathy at a previous screening. And that in itself is important because by definition, mild non-proliferative disease is non-sight threatening. And this patient is now experiencing reduced visual acuity. So something has changed quite clearly, and it's likely to be related to the diabetic retinopathy. We can't say for sure at this stage. Her blood pressure is elevated, she's overweight, non-smoker, but is consuming alcohol, so her lifestyle isn't as good as perhaps it could be, or maybe her diabetic control could be better. When we look at the OCT, again start out with the Fundus reference image. Are there any signs of diabetic retinopathy visible within the Fundus reference image? Again, it's clearly visible retinal hemorrhage. But that's something we associate with mild non-proliferative disease. There are microaneurysms visible, again, a sign of mild non-proliferative disease. But there's a large area of absorption of infrared light, which again would imply fluid somewhere either within the retina, underneath the retina, or underneath the RP. When we look at the OCT cross-section, we can quite clearly see fluid-filled voids within the OCT cross-section. And these are at the level of the ganglion cell layer, the inner nuclear layer, and the outer nuclear layer in front of Henle's fibre layer. And where the cysts are forming is where we anticipate we would see retinal blood vessels within the OCT cross-section. Now, diabetes is a disease of the microvasculature in which we see one of two things, either leaking retinal capillaries or blocked retinal capillaries. So we've got quite clear evidence of breakdown in blood-retinal barrier, but this time it's now the inner blood-retinal barrier that's affected, the retinal capillary bed, which is leading to intraretinal fluid. There's a small area of subretinal fluid as well, and remember that the RP acts as a metabolic pump, regulating hydration in the retina. So if you've got a very leaky capillary bed, the RP may not be able to cope with the fluid production, and that's why we've got some subretinal fluid as well. The OCT map again shows thickening with a central subfield of 460 microns, which will become important. The fundus image again shows signs of progression of the disease. We've got some evidence of vascular sheathing, so there's a white vessel. There is a small abnormal looking vessel group, which may be an intraretinal microvascular anomaly, so we're probably looking now at moderate to severe non-proliferative retinopathy. There's evidence of exudate visible as well, which is again a sign of maculopathy, which again sight-threatening retinopathy, which requires referral. The green colour on the multicolour image indicates that we're also looking at retinal edema, and we can see some cystic change en face as well. So this patient's diabetic retinopathy and diabetic maculopathy has got significantly worse, and therefore we need to be thinking about referring the patient on. But also engaging the general healthcare practitioner as well in terms of the patient's ongoing diabetic care. On-face OCT can be useful in that it allows you to demonstrate the distribution of the retinal cysts, and the measure of central retinal thickness is important because that means if it's 400 microns or greater, then the patient would be eligible for anti-VEGF therapy under NICE guidance. Again, that's not a decision that we've made necessarily by the optometrist, but being able to gather that information and include that within your referral may very well be useful. Fluorescein angiography still has a role to play in terms of investigating patients with diabetic maculopathy, because we need to reassure ourselves there's not an ischemic component to the maculopathy, and therefore the integrity of the foveal arcade needs to be assessed using angiography. Obviously, fluorescein angiography also allows us to pick up other microvascular changes, neovascularization elsewhere, and then neovascularization of the disc. OCT angiography may very well provide useful information in that it will allow us to get a good structural assessment of the retinal vasculature without resorting to an invasive procedure. But again, that's for the future. This is very new developments in terms of imaging of the eye, and I think will more become clear over the next 18 months to 2 years as this technology starts to become more widespreadly used. This case focuses on another elderly patient, starting with a sudden change in vision and clearly described distortion. Visual acuity is 6.9 or 6.24, which perhaps isn't as low as you might expect. Sudden loss of vision though. Mother's known to have lost some central vision as well.
I'd like to introduce our next patient, who's an 88-year-old man who has a history of reduced visual acuity in both eyes and of dry age-related macular disease. He is a smoker, and the acuities in this case are 6.9 in the right eye and 6.24 in the left. And he presented with sudden change of vision with metamorphosia. And so I'd just like to have a look at this case and perhaps discuss what you think the images tell us and how we would best manage him.
It looks like there's some sort of elevation there, so fair view. I don't know if that would be a build-up of subretinal fluid.
And it's over a small or a large area?
Over a large area.
Quite big.
Yeah.
Would you say that was consistent with the visual loss that the
Would have
patients
thought
received,
so.
6.24?
I don't know if it'd be a little bit worse, if anything, looking at it.
Might be. And would that account
It
for
would-
the
it would make-
distortion that the patient's getting, do you think?
Yes, I think so.
So is there any other features of this image that anybody would like to point out?
Well, if you take the vertical cross-section, we've got what appear to be two different kinds of elevation. It's as if the sensory retina is elevated, and then as we go along a little bit further, is that a pigment epithelial detachment? The pigment epithelium's raised as well, and then as you go further along that image, again, there's a bit of sensory retina come off. So we've got kind of two different things going on.
Do you think that's two separate things or part of the same?
Probably part of the same problem,
Yeah.
but two different observations to make.
Yeah. And does anybody disagree with that?
Yeah.
Right. So is there anything else that's is of interest in the images there?
On the horizontal, there seems to be some breaks either side of the pigment epithelial as well.
What do you think the significance of that might be?
Not sure, it could have been possibly how it started.
This patient says that it's a sudden change in vision. Do you think that's likely, or could it have been going on for a lot longer than just sort of very, very sudden?
My feeling is it's quite sudden, and also on the fundus photo and also on the OCT scan, it shows that there's more fluid going downwards, which would account for gravity. So I think this is a progressively advancing wet macular degeneration happening.
So this is progressively advancing. So you said it was sudden and then progressively advancing.
It appears to be getting worse. So I suspect it's been there a short time, and it's getting worse.
Right. So does anybody disagree with that?
No, I think it's a reasonable analysis.
And so what would the differential diagnosis be? Could it be anything else other than a wet macular degeneration, do you think?
I think the hallmarks are fairly clear on the OCT, so I'm not sure what else it would be.
Myopic. We don't know how short-sighted he is. Is he a super high myope? Probably not, looking at the
got the
picture.
information.
Yeah.
So the disc appearance isn't.
No, it's not consistent with high myopia.
So if we're not really sure or what it is, but we know it's sudden loss of vision, what would you be inclined to? What would you be inclined to do?
Urgent referral, I think, to a hospital.
So via Casualty or through the GP or?
Via Casualty. If I was certain it was a wet, then I'd fast track it through the wet AMD
Right.
scheme.
So, but you definitely want that patient to be seen quite quickly.
Yeah, I would have thought so.
What do you think the patient will do when, what do you think the hospital will do when the patient gets there? Anybody got an idea what workup they might
Fluorescein
do?
angiography.
Fluorescein?
Repeat OCTs?
Probably, yeah.
Dilate and examine,
Mm.
and I suspect that this patient's going to go through the wet AMD channel.
Right. What do you think about the other eye? Is there a risk that same thing might happen to the other eye?
Yeah.
Without a doubt. So that would obviously be assessed as well.
What do you think the treatment may be, assuming that the diagnosis is wet age-related macular disease?
What would be an anti-VEGF type treatment nowadays? Assuming that it was a standard type of wet AMD. I know there are so many different types of occult types of wet AMD which are beyond my knowledge.
Mine too.
So the patient's going to expect
An ongoing pattern of treatment for probably a couple of years.
what do you think the prognosis is?
I think it's pretty good because if we look at his retinal pigment epithelial layer, from here it looks quite intact. So I think he's got potential for a good prognosis.
Although it says history of reduced VA, both eyes, dry AMD, so it's probably around this. Well, assuming because of the right eye is 6'9" at the moment, he's probably no better than 6'9" before he walked in. Sorry, before the event happened. He's also a smoker. If he persists with that, then the chances aren't as good.
I wonder about an 88-year-old smoker, though. I'm going to be lenient to this one. I'd say relative to his expected life, or how long he's going to live, whether it will make a lot of difference whether this gentleman stops smoking or not. And what's to be gained, how does he feel about it? I've also seen some patients with similar sorts of conditions who've declined treatment because the other eye is okay and I can't be bothered. So it depends at the age of 88 how with it he is, how agreeable he is to having a lifestyle change and going through this treatment of anti-VEGF, which isn't particularly nice.
I think from a clinical perspective, though, I think we have to give the same advice across the board, whether they're 45 or 80 odd.
What happens to him afterwards is going to be obviously partly his decision also, but the pathway remains the same.
Anybody feel that they'd like to add anything?
That's just one thing I didn't quite understand was I read somewhere that when there's a large elevation, that sometimes when they're treated that the RPE can then sort of crash down and you end up with it breaking or splitting. I didn't know whether anyone knew any more about that. That's the limit of my knowledge.
Anybody?
We don't get much feedback to know how was it before, how was it after, and I think that one of the things that the OCT will help us to get is more experience on expectation.
I think it depends how intact the photoreceptors are once it's back to. If you can get rid of the fluid, how intact is that photoreceptor layer? Because sometimes if that's gone, you're not going to gain the acuity. Is that right?
The fundus reference image shows a clearly circumscribed circular lesion with pigmentary change centrally. And the OCT cross-section very obviously shows a very large dome-shaped retinal pigment epithelial detachment. There is also increased reflectivity in the neurosensory retina, evidence of some subretinal fluid. So again, changes that we would normally associate with wet age-related macular degeneration. The vertical cross-section more clearly shows a large inferior neurosensory retinal detachment, and again a large pigment epithelial detachment. The important feature to look at here is that we can still see the drusen at the apex of the RPE detachment, and that gives us an indication that Bruch's membrane is still attached to the rear of the retinal pigment epithelium. There's also some hyperreflective material underneath the retinal pigment epithelium as well, which again will become more important as we go through the case. The OCT map, not unsurprisingly, again shows gross central retinal thickening, which extends inferiorly. And the colour image shows the appearance of a large RP detachment with drusenoid change over the surface, and again a neurosensory detachment inferiorly. The infrared reflectance image shows the pigmentary changes most effectively, and the green reflectance image shows the neurosensory detachment most effectively. Next step in terms of investigations in hospital almost certainly will be angiography to establish a baseline of the subtype of wet AMD that the patient may be suffering with. And it's the late phase images that quite clearly show a large RPE detachment with occult choroidal neovascularization visible on the ICG angiogram. Treatment is almost certainly initially a VEGF antagonist in terms of treatment, although for patients that don't respond, again, further ICG angiography might be indicated to eliminate the possibility of two subtypes of wet AMD, polypoidal vasculopathy or retinal angiomatous proliferation, both of which don't respond well to anti-VEGF therapy on its own. So additional investigation may then allow the ophthalmologist to tailor the treatment for that particular individual. This case focuses on a 60-year-old male with loss of central vision and superior field. Visual acuity is reduced down to 660, so significant visual loss, with elevated intraocular pressure in the right eye. Patient's a known glaucoma sufferer on treatment. He's also got elevated blood pressure.
This is a 68-year-old male with slightly elevated intraocular pressures and a diagnosis of glaucoma. This patient is taking glaucoma medication. Is retired, presents with a Snellen acuity of right 660 and 6.6 in the left, and intraocular pressures measured 23 in the right and 18 millimeters of mercury in the left. In terms of his history, there's a loss of central and superior visual field, and the patient presented as a self-referral because he had noticed that he was finding it more difficult with his visual field. If you'd like to have a look at these images and just perhaps start off by describing what the images are and the features of them.
To me, this looks like, I want to jump in and say it looks like a branch retinal vein occlusion going on with quite a lot of inflammation in the intraretinal layers, which has obviously caused the field loss superiorly.
And do you think that's consistent with the patient who's got known glaucoma over a period of time and has been medicated for a while, self-referring with new visual loss?
Not necessarily. I think that the field loss could be caused by the glaucoma, obviously.
If the patient was used to a field loss that he's habitually had because of the glaucoma, would he self-present with a further field loss that was concerning him between hospital appointments?
Normally he wouldn't, so I can assume that this is a relatively new event.
Would everybody agree? Yeah. I'm trying to ask. Sorry, I interrupted you. You were going to talk about the Fundus image.
Well, what I'm trying to do is separate the glaucoma from the branch retinal vein occlusion, if possible.
Are they related, or could they be?
Well, they could be. This is just it. They could be. So I'm having difficulty in separating them now that I look at the pattern of the vein occlusion. So they could well be friends.
Does anybody else feel that there's any other features that we need to discuss, or do you think we've got it cracked in one go?
I very much doubt that with me.
I'd like to talk about the disc actually, because the disc, the thinning of the neuroretinal rim on the disc looks to be the superior edge, and actually, is that a wedge defect in the fibre layer superiorly as well? So he's probably got inferior field loss for the glaucoma rather than superior.
It'd be nice to take a OCT scan of the optic disc as well, wouldn't it, to see if the nerve fibre layers are all intact.
Would be. But in terms of managing the presentation where the patient's symptoms are, I've noticed my visual field's not so good, and maybe the acuity is reduced slightly. Is it the branch occlusion that we're worried about here, or is it the glaucoma?
It's the branch, because he's already been treated for glaucoma anyway. So it's the new pathology that we're concerned about.
So we've got the new pathology. So we're pretty sure about the diagnosis here. What do we think we should do about it?
Needs urgent referral because of risk of neovascular glaucoma.
Right. What might the treatment be, or would there be any more treatment?
One thing that we haven't mentioned so far is his right intraocular pressure is raised.
It is.
So it's quite possible that his control is not as good as we had hoped. And it's quite possible that this could be causing branch vein occlusion due to the raised intraocular pressure or poor control.
Right.
So with referral, it's possible that they would first look at getting his IOPs under control. He'd obviously need a full blood workup as well to see if there's anything else going on, because his general health, I've got nil down here, which I assume that's fine. Or was
I've got no indication to suggest that it wasn't.
And there's nothing about medication taken here, so there could be other factors apart from just raised intraocular pressure.
So you think that they'll deal with the raised intraocular pressure? What other investigations might this patient possibly have to undergo? Has anybody got some suggestions?
Diabetes, hypertension.
Will there be anything else that might be useful?
Fluorescein angiogram.
Anybody else?
Gonioscopy.
Gonioscopy, possibly. Yeah. So, do you think that any or all of those are likely?
I think all.
All of those.
Yeah.
So, what further treatment might this patient be offered, do you think?
Laser treatment.
What would they laser?
Retina.
Okay, and for what?
To prevent the risk of neovascularization.
Right. And that would be the prime concern?
Short-term concern, for sure.
Are there any new treatments for retinal branch occlusions that you can think of?
Yeah, I think intravitreal injections are indicated. I'm not exactly sure what. I think steroids are used in this sort of case. But then I was thinking about steroids. Then I started thinking about intraocular pressure.
Yeah.
So this is getting complicated now.
Yes, the same. I went through the same path as you. I think I thought, oh, could you implant some sort of steroid implant? But then, would they do that because this person's got glaucoma? And I didn't come to a conclusion. I think that's the obvious decision, isn't it?
Accurate diagnosis is where we have to be first.
Right.
Was it the glaucoma? Was it something else going on? And that would indicate which treatment is to be used.
So urgent referrals, so that somebody above our pay grade could
or somebody
sort
easy.
that out.
Yeah.
There are more than one
Several
condition,
of them.
possibly more than one.
What do you think the prognosis is in terms of the acuity? Because the acuity's dropped to 660 in this patient.
It's dropped from 660, but we don't know from what. Whether it was already a poorly controlled eye. Looking at the disc, possibly not. But it does depend where we came from as to where we're going to. There isn't any doubt that the vision has gone down looking at the fundus.
Just kind of ask people what they think. Is it if this patient was a driver, still was driving up until this point, would that have any implications for his ability to drive, do you think?
I think there are two considerations here. First is what's the overall binocular field, and the second is how is he coping with it. So if he's feeling uncomfortable with it, then obviously he should stop. And if the overall binocular field was reduced, then also he should stop. So it's the newness of the condition which is the issue here.
Anybody else got any?
We don't know how well preserved the field is in the fellow eye, of course.
Mm.
So,
He might be 6'6" with enormous field loss in the other eye. What's interesting to me is the vertical line image. The inferior retina looks quite abnormal, it's raised, there's cysts there. But just as we meet the fovea and superior to that, the retina looks quite normal. So why is he 660 in that case? Acuity seems like slightly lower than I'd expect, given that sort of appearance on the OCT, is it?
I get the feeling the fovea is elevated in that section, and that's what's throwing it. So we've got the big bump on here. Isn't that where the fovea is?
Yeah, but then it returns to normal so close to the fovea that...
On this side.
It's just nudging that sweet spot, I suppose. So once again, pinholes would be useful.
Does that suggest that if the edema can be reduced, then the prognosis is better? If you think part of the macular area is preserved?
You'd expect a better prognosis.
I'd like to think so.
So in this particular case, our role is to make sure that the patient gets an urgent referral and that the ophthalmologist can work him up properly. So nobody wants to add anything more.
I think if they can't see their ophthalmologist, sometimes you can get through to the secretary of that particular ophthalmologist if they're already under somebody. Sometimes you can nudge things in that way, but I think if you can't see the ophthalmologist urgently, i.e. he gets an appointment and it's in 3 weeks' time, you should at least be seeing the GP within a few days to check the cardiovascular health.
If that were to be the case, that the patient wouldn't see an ophthalmologist for three weeks, would you be happy with that, or do we think that maybe we should be doing something else?
There's not a lot else we can do, is there? We can't administer the injection or anything ourselves, so we'll have to just leave it up.
I think if I knew I'd made the ophthalmologist aware of all the findings, I'd sent a referral, I'd sent some images as well, so they were very informed, and they've made a decision as to when they're seen, then I'm not sure I can change that particularly, can I?
It's difficult. It comes back to the dilemma of some of the earlier cases where you feel like you want them to be seen urgently, but not necessarily have the confidence that will happen via the normal route. But you can't send everybody to Casualty just to get them seen. And
so if you've taken advice and they've said you've got to wait, you've got to wait.
I guess so. You could always ask them if they'd rather go privately. That's some kind of...
The three routes that I can see are privately, as you said. Referral via GP urgent, which is never going to happen, because it will sit in a pile for a while, and the letter will sit in a pile. And the third method is Casualty method. Now, when we're treating or seeing any patient, the politics and waiting lists are something I really don't care about. The reality is to have done the right thing for that patient at that particular time. So it's a patient-by-patient scenario for me. And if Casualty is blocked up, then they still have to deal with it, and it must be dealt with. So my preference would be to send the patient via Casualty, and the politicians will have to deal with the politics.
Does anybody like to argue against that?
No, certainly couldn't argue against it. I think, again, in my area, it's send a letter or it's phone call and then it's urgent, and we've not got that slightly in between a few days method. So I would get on the phone, speak to someone, or at least know that the ophthalmologist is aware of what's going on, and I've had something back to say, we know about this. But the best thing to do is see if you can speak to someone, I think.
If that patient hadn't come to you and gone straight to Casualty, how would they have dealt with that?
There are a couple of routes. Sorry, I work in Casualty part-time. There are a couple of routes locally. The first would be an internal referral, and it depends what the person in Casualty, the ophthalmologist usually, or sometimes optometrist, was seeing. So the patient would either be referred internally and dealt with internally, and the system locally is quite good for that. If it was felt that this wasn't urgent, then the patient is rebounded back into the GP system for referral back in routinely. In this particular case, that probably wouldn't happen. They would be seen internally.
So you've got experience working in the Casualty department, so if this patient had presented direct to Casualty and you had seen them, we'll use your experience if we may. What would you do?
Oh, quite easy. It's great to be an optometrist because you can pass the buck. But what would happen is that this patient would have a full workup. They would then have an OCT done, The results would then be presented to the boss, who's an ophthalmologist, and they would make the final call.
So they would get their opinion from an ophthalmologist?
Yes, without a doubt.
Having been examined, or at least assessed.
Always. And medical retina have got slots that they will open up if they feel necessary. But it's got to be an ophthalmologist's decision eventually.
Right.
The optometrists in this sort of case would be merely assistants, which is fair, I think.
Yeah. Good. Well, I'd just like to say thank you very much. And that's the end of our final case. So thank you.
The infrared reflectance image shows changes that are confined to the inferior hemisphere. There is evidence of a large dilated retinal vessel, which on closer inspection is a retinal vein. The changes, the absorption of the infrared light is secondary to intraretinal edema, and the OCT cross-section, which is a horizontal cross-section intersecting the fovea, shows cystic change. The vertical cross-section shows the superior half of the retina looking normal and the inferior showing gross retinal edema. And the OCT map, the changes, the thickening, retinal thickening is confined to the inferior hemisphere. In actual fact, it's probably the fundus image that's most revealing in this particular case. There's widespread inferior hemorrhaging, multiple microinfarcts and dilated vessels in 2 quadrants. So what we're looking at here is not a branch retinal vein occlusion, but a variant of central retinal vein occlusion, hemisphere vein occlusion, where the occlusion occurs at the level of the lamina cabrosa. The patient is a glaucoma sufferer, and there's clear changes in the optic nerve head in that there are superior notching visible. There may very well be inferior changes to the rim as well, but with the gross retinal edema, it's difficult to assess the inferior structure of the nerve clearly. There is also an superior arcuate retinal nerve fibre bundle defect, again typical of glaucoma. We know that glaucoma is a risk factor for vascular occlusion, and so we've got elevated intraocular pressure plus elevated blood pressure. This patient's going to have perfusion problems potentially. Investigation, we need to assess the integrity of the foveal arcade. The grossly reduced visual acuity implies that there may be an ischemic component to the patient's visual loss. Fluorescein angiography will also reveal whether or not the patient's got widespread peripheral ischemia as well, in which case we're obviously concerned that neovascular glaucoma may be a complication for this patient. The patient's blood pressure is elevated and they've got evidence of retinovascular disease, so informing the GP and engaging their input into the patient's ongoing care is obviously important. Treatment in this case, first-line therapy seems to be anti-VEGF therapy to deal with the effects of the macular edema. And again, if there's persistent or extensive peripheral non-perfusion, then laser treatment is still available as an additional treatment to prevent the effects of rubeosis. The use of steroids in retinovascular disease is concerning, particularly in a patient who has a history of glaucoma. In the early days of treating macular degeneration, intravitreal triamcinolone injections were used, and whilst this dried out the macular degeneration very, very rapidly, it also caused some very aggressive glaucomas, which were very, very difficult to manage. So steroids is not generally a first-line therapy, or long-term steroid implants are not generally a first-line therapy for central retinal vein occlusion. Intravitreal steroids can be used and do produce good resolution of macular edema, although increasingly there seems to be a move towards VEGF antagonists as a therapy for macular edema and vascular occlusive disease.